Yeah, one of those. Epidemiology and public health, but with an interest in shared decision-making and health services research.
And also from primary care and working as a researcher now.
Okay, thank you. Then we are going to have the second speech of Devlin Weiss.
Thank you. Dimple Vyas. I'm a consultant anaesthetist with special interest in chronic pain management, working in an acute care trust in the United Kingdom. And I've been working on the Co-Creating Health initiative with the Health Foundation for last 4.5, 5 years or so. And I'm also going to start some work with IHI starting this July as a Quality Improvement Fellow.
Thank you very much. And then we will learn how to get into the TripAdvisor with Felix. Please introduce yourself.
Absolutely. I'm Felix Greaves. I'm a junior doctor and proud from London, Imperial College in the UK. And I'll be talking about TripAdvisor stuff.
Thank you so much. So let's start with Elwyn and Richard, please. So we have a presentation, and please write and look for questions. After you can ask questions.
Right, well, is that working?
Yes.
Okay. First of all, Glyn and I are going to do this as a duet, but we are actually presenting on behalf of two excellent teams in both Cardiff and Newcastle who have helped us to get to the situation we're in now, which is learning from a national project supported by the Health Foundation on implementation of shared decision-making. How do we actually get this into practice? So this has been a joint programme. We've recently completed the first 18 months and are about to go into phase 2. I've taken a role in Newcastle. Glyn's taken the lead role in Cardiff. But as I say, we rely on some great teams who've worked behind us. And this is a project that worked across 2 healthcare communities and 2 academic institutions, but is increasingly shifting into the health sector as an implementation transition programme. How can we actually do this in day-to-day practice? But first, a bit of background. What do we mean by shared decision-making? Well, we're talking about, and you've heard about this in several other occasions this week, we're talking about an interaction that recognises that there are 2 experts in any clinical interaction. The clinical expert and the patient, who is the expert on their own feelings, their own preferences, what's important to them. We've heard what matters to you from the very beginning of this conference. And a good shared decision is one where the patient's informed, they're knowledgeable about the right things, they know what the options are, and they know what the risks, benefits and consequences of those options are. But they also know what's important to them, and that may need to be supported and brought out. And then they make a decision in collaboration with their clinicians, often in collaboration with their family and others, that's consistent with what's important to them, with their preferences. And they follow that through. Do we do this well? Well, in the UK we can certainly do it better. These are data from NHS inpatient surveys over a period of 10 years. This is not changing dramatically over that period of time, despite the apparent policy emphasis on better engagement of patients in decisions about their care and treatment. So about half of the patients after discharge from hospital in the UK wanted more involvement in their treatment decisions. So let me quickly describe what MAGIC is about. This is making good decisions in collaboration, and it's focusing on implementation. We developed a multifaceted implementation strategy that had several components to it. Evidence-based patient decision support, an element of social marketing and clinical skills development, awareness raising and developing the skills of the clinical teams, an approach that recognised the importance of both organisational and clinical team engagement, and one that was about active learning as we went through. We didn't know exactly how to do this. We wanted to learn as we went through in a very reflective, rapid feedback, quality improvement way, how we could continue to implement this effectively. And, last but not least, a thread of patient and public engagement that works throughout the programme. And in both of our centres, we had a mix of primary and secondary care clinical teams. some of which were focused around implementation of a particular patient decision aid, others of whom were more about implementation of shared decision-making and the skills of shared decision-making across their teams in a number of settings. To cut a long story short, at the first stage of this, at the end of the first 18 months, we've identified several key challenges, and we want to talk you through those briefly and what we've developed and tested as the solutions, at least the interim solutions to those challenges. And these are the challenges, the key challenges, one of which is we do it already. Now that's a good thing actually, because it means that clinicians are not saying we don't want to do this, but there is a challenge there, because if people think they're doing it already and the data, which I've already shown you, suggests they're not, then there's a bridge to create. We don't have the right tools. Okay, another key issue. How can we get the right sort of information at the right time to the right people to support shared decisions? Does it make any difference to our patients? Perfectly reasonable question. Clinicians, patients don't want it. They say to us, "Doctor, you tell me what's best." Patients, "I don't feel I've got the permission to be involved. This is not what I've been used to experiencing in healthcare." And then, at the sort of organisational level, are we aligning shared decision-making with the organisation's priorities and goals? And is that engaged across the organisation? So, first challenge, we do it already. The key to this, in our experience in the first 18 months, has been developing and supporting clinical skills, particularly the skills of what you might call the second half of the consultation, areas of decision-making. And one of the key components of this has been skills-based workshops, focused around the opportunity for clinicians to practice and try out the methods of a good shared decision-making consultation. So focused around role play. Initially we did this with actors. We've moved on to facilitating within the training workshops that we're using, but focused around small group work, role play, continuous feedback, and learning as we go along. And that's been really critical. I'm not going to talk about these in detail, but simply to say that our initial evaluation of the workshops has demonstrated that they're very positively received, and that the clinicians at the end of it feel that they're able to do something different. And in particular, some of the qualitative feedback that we've got has been along the lines of, you remember the challenge, we're doing it already. Often what we're hearing back is, we thought we were doing this, now we realise that we can do it a lot better. Second challenge, we don't have the right tools, and here I'll hand over to Glyn.
Thank you, Richard, and thank you for coming, everybody. We don't have the right tools. In other words, we don't have the right information at our fingertips. The solution? Well, some of you may have heard of decision aids. They're been developed over the last 10 years. One of the difficulties is that they're not that available to clinicians, and certainly not to patients. And the other problem with the decision aids that have been traditionally made over the last 10 years is that they're quite extensive. They don't fit into the face-to-face consultations. So solutions that we've arrived at in Magic, in Newcastle and in Cardiff, is to generate short tools that fit into the dialogue. We've called them option grids in Cardiff. Richard and his team call them brief decision aids. But what they critically do is to provide information which catalyzes a different sort of communication. I'm just going to show you the example of the ones that we've been producing in Cardiff, which are option grids. And here I want you to imagine yourself facing early breast cancer and being asked to consider whether you'd like to have a lumpectomy with radiotherapy or a mastectomy. Imagine yourself in that situation. You maybe the first thing you might realize is the shock of being given a choice. Why am I given a choice? Surely there's a best thing to do. And what we've realized, I think, is the beauty of organizing these grids by a frequently asked question. In other words, giving the patient in front of you the permission to ask this critical first question. Which surgery is best for long-term survival? Answer? There's no real difference. All the trials show no real difference. Maybe another question then pops into your head, and we encourage patients to read this, if they can, with the clinician. It'll take you about 3 or 4 minutes. What are the chances of the cancer coming back? And you'll notice here there is a difference in the cancer coming back in the breast. 5 in 100 in mastectomy, 10 in 100 in lumpectomy. And the patients often work this out. Oh, that's a double the rate. In other words, the relative rate. But they also got the absolute rate here. Now, these grids are on one side of A4, and that's critical because you get cognitive overload if you give too much information in that consultation. And what I think we've realized is that these are not everything that the patient wants to know. There's more that they want to know, but it's a very good catalyst because it does a couple of things. It visualizes the options, makes them very concrete and visible to the patient. It standardizes the information that the clinicians will give. They're all using the same facts. This is just as helpful for the general practitioner as it is for the nurses in the clinic. And it kind of operationalizes shared decision-making without you having to think about those skills that you might need. Give people these, encourage them to ask a question. And we often give the patient a pen or a pencil to say, write your notes on these, ask some questions. And one of the beautiful things that one of the consultants told us is, why don't we say, take time to read it whilst I take permission to work on the computer? So they spend 3-4 minutes on the computer while the patient, if they can, of course, reads the grid. So a win-win for both the professional and the patient. And I also think it kind of focuses on the key trade-off points. That's a key trade-off, the risk of the cancer coming back. The other key trade-off in this decision is whether you need 6 weeks of radiotherapy. And maybe if you're elderly and have difficulty with transport, that might be a problem for you. We've actually got quite a few of these made. You're welcome to visit this option grid website. You should find it on Google. So we're finding that there's quite a lot of interest in these short tools. So please feel free to take a look at those that we've made. They're available free online without a password. And I guess what we feel quite happy about in the Magic in Newcastle and Cardiff is the conceptualization of this simple model for shared decision-making, the one that we teach in the workshops. Introduce choice, do a bit of choice talk. In this situation, there are more than one option. Give more detail about that choice in terms of describing the options and having that data at your fingertips, usually in a short form or something like this. But then build the bridge to more extensive information, which patients often want. And what I think we've critically realized in this model is that this is not a one encounter, one consultation process. Patients say, oh, I didn't realize it was this involved. I need time to go away and think about it, discuss with my family, my friends. So starting shared decision-making is the beginning of a journey of decision-making. And here's where you might want to point patients to web-based tools. I know that in the UK there are a series of these being made at the moment. So I'm coming back to decision talk, where you make this patient journey between prior preferences to informed preferences. And in a nutshell, this would be shared decision-making. Now, the other challenge was, does it make any difference to our patients? And here's where we've borrowed the concept from Karen Sepuka and Al Mully in Boston and adapted what they've called a decision quality instrument. We've called it a decision quality measure. This is the reference, if anybody of you want. That's the initial approach. And here's what we've been focusing on: measuring knowledge, preferences and readiness to decide, and perhaps the preferred choice of treatment. And we've been able to demonstrate, I think, shifts in patients' readiness to decide from the initial consultation where the nurses are asking about their readiness to decide when they've got the breast cancer, to a home visit 3 or 4 days later where they've been using an option grid, and their readiness to decide, their confidence in knowing the options and so on, has just dramatically increased. So we've been demonstrating this. We've also been demonstrating a shift from the middle ground of being not sure about whether you want mastectomy or lumpectomy to people going in both directions to the sides, to a strong preference for lumpectomy or a strong preference for mastectomy, but also on the basis of being informed. Here's, when we first were starting the work, the knowledge base, and here's the key questions based on some data in the option grid again. And what we've noticed is that the nurses have been consistently getting better at informing the patients, again using the option grids in Cardiff, demonstrating shifts in information. And the hypothesis we have, and we want to do more work on this, that provided you're ready to decide and also informed, you're making a decision of high quality. And what we've noticed here is that when we've gone away, the feedback from these tools to the nursing teams is something that they value so much that they keep on doing it. They really want to know in the moment whether their patients are becoming well informed. So the measures are not for us as researchers or evaluators. They're actually feeding back instantly into the clinical team, and they keep on doing it. Over to Richard.
So the next challenge, patients don't want it, and patients feel that they don't have the permission to be involved. We did a systematic review a few years back on the factors that influence patients' preferences for involvement. And one of the key findings from that is that there was an age-related relationship. Now, I don't believe that as you get older, you want less involvement. I think that's a reflection of the type of experiences that people have had over their lives in the experience of interacting with health services that they've become used to and have come to expect. That being the case, then as well as, if you like, skilling up our clinicians, we also need to engage patients and the public in changing their expectations as to what might occur in a consultation that's about shared decision-making, rather than the traditional paternalistic model. You tell me what to do, doctor. And again, we've adapted some work, in this case from Australia, around brief questions that patients might ask in a consultation, or at least seek the answers to, regarding understanding their role and being supported in choices. Those questions are, what are my options? What are the possible benefits and risks of those options? And how likely are the benefits and risks of each option to occur? In Newcastle, we've slightly adapted that. I don't know whether our patients in Newcastle are different to those in Cardiff in any way, but certainly we heard back from clinicians and patients that they wanted to ask a question, how can we make a decision together that is right for me? But the differences are less important than the core of this, which is supporting patients in thinking about a different sort of consultation. In the Magic programme, we've also produced a brief video where patients talk about their experiences of having shared decision-making consultations around these sorts of questions. And I think, although we don't yet have the data for this, that actually often this video is being more influential for clinicians than it is for patients. We're running it in waiting rooms in primary care, we're running it in waiting rooms in hospitals, and our clinicians sort of tell us that they don't hear a lot of patients coming and asking those questions, but they're thinking about those questions and whether they're giving that information to their patients as a result of this. So I think there's some interesting issues there, but nonetheless, there is a need to shift the way that patients expect consultations to occur in future. And then finally, does shared decision-making align with organisational priorities, and is everyone engaged? I wouldn't say we've cracked all of this as yet, and one of the major tasks as we move from phase 1 to phase 2 of the Magic programme, and the Health Foundation have agreed to support us into a new phase to test out some of this learning in the next phase of development. And I think this is one of the key areas that we still have some work to do on. It's clear that, as in any setting of implementation and change in healthcare, that there needs to be organisational leadership and commitment, and we've tried a number of engagement strategies to address that. In the UK, there's quite an emphasis, as in other settings in North America as well, on shared decision-making. In our health policy at the current time, there's a lot of focus on no decision about me without me. What we found is actually quite a mixed response to that at the grassroots level. There are those who seize upon that and say this is fabulous, and there are those who say it's just a phrase. So there's some interesting issues about how one sees the embedding of national policy at a local level. But what we have learnt, maybe no surprise to many of you in this audience, was the importance of clinical champions and their teams. Not just in terms of embedding shared decision-making within their own teams, but increasingly how they then transfer that learning across to other teams within the organisation. We felt it important to incorporate QI methods and reflective practice as part of the process of implementation. Now, that's not been easy either. Certainly in Newcastle, to a lesser extent in Cardiff, who are already involved and were already involved in some QI work around patient safety, we found that actually people weren't yet ready or prepared for some of the methods that many of you already feel comfortable with. So there's some challenges there. We need clearly to get board level and middle management engaged. And that's about evidence of engagement, not just lip service to that. And in some of our clinical teams, particularly in secondary care, I think we made mistakes in the early stages of not involving middle management at the appropriate stage, the people who perhaps had some control over the resources within the teams. So we majored on clinical champions and really had to get back in and let's draw the whole team together into this. And then we faced some challenges in all healthcare systems, and we heard some of this from Nigel Edwards' talk the other day about competing incentives. So waiting and treatment time targets may be counter to some of the additional reflective time that Glyn was talking about just a couple of minutes ago. And are we measuring it? And can we measure it? And there are some real challenges of measurement of implementation of shared decision-making, which is for another discussion, I think. But what gets measured gets done, and this is not yet what is traditionally being measured as part of the way that organisations in healthcare and the NHS address their reflective processes. And there are cost-effectiveness and efficiency pressures. And what we have found, though, is it is helpful to link, where appropriate, to existing initiatives. So in Wales, as I've mentioned, the involvement in the 1,000 Lives campaign and the QI methods that were embedded within that have proven supportive to implementation of shared decision-making in Cardiff and Vale. In Newcastle, we found that linking this, for example, to the clinical negligence scheme for trusts, where in the UK trusts are banded in terms of their risk management, and were able to incorporate the introduction of shared decision making as part of that external audit process and benefit from it as a trust. So, in brief summary, we've given you a rapid run through of our learning at sort of the high level. And we'd be delighted to talk to individuals about what we've learnt in more detail. We do it already, the importance of skills development and workshops, and giving the clinicians the capacity to practice and develop their skills. We don't have the right tools, the value of brief decision support tools that can be used within the consultation, within the model that we're teaching within our skills workshops. Does it make any difference to our patients? Being able to measure, as Glyn described, the decision quality changes, the knowledge changes, the improvements in readiness to decide, and demonstrate that to the clinical teams. The patients don't want it. I don't feel I've got permission. How can we better support patients to have a different expectation of the consultation to the one that they've grown up used to? And the challenges of key organisational leads and the various strategies that we need to implement to support that. We won't do this unless we address that sort of multifaceted approach. I'm reminded at this point that someone once said to me, any problem is easy to solve. For example, if you want to create an elephant out of a block of marble, it's a simple thing to do. You just get a hammer and chisel and chip away everything that doesn't look like an elephant. It's not that easy, but we can get on this road and we are moving in the right direction. Thank you very much.
Thank you so much to our speakers. First of all, I want to tell you that you will find all the slides of the presentation, and you will receive a message from the forum team, and so you will know when the slide will be posted into the website. So you will find all the slides. We have a few minutes, but we can get 2 questions to the speakers. Yes, please.
Alan Nye, General Practitioner and Clinical Lead for Aqua for Shared Decision Making. Richard and Glyn, I think you've highlighted some of the challenges we face. I think for me the main challenge is how do we roll out shared decision making from a well-motivated and resourced structure such as MAGIC into the wider community of standard healthcare. If you had to choose one lever we should be concentrating on, can I ask you what you feel would make the greatest impact to begin to get shared decision making widely accepted?
I'll kick off first, and I'll hand to Glyn. First thing is I duck the question because I don't think there is one lever. The issue I would re-emphasise here is you need to bring a whole load of elements of influence together and align them if we're going to get this sort of change. Having said that, and some of those levers are not open to us within the MAGIC programme. Now, in Newcastle, we're about to explore how we can get clinical commissioning groups engaged in this process as part of the changing nature of the way that healthcare is commissioned within England, not in Wales. So that's a lever we're about to begin to explore as to how that might occur. But I think there are other levers that are at the current time out with our control, such as the role of professional bodies in driving forward this in terms of educational initiatives, requirements for training and accreditation and so forth. And I guess if I was going to choose one area, that might be the one that really needs to be addressed. Starting from undergraduate education and working all the way through the process, but making it real so that it is examined and taken seriously as you move through that process.
Tough question, Alan. I mean, Richard's given a very good series of issues and these elements. And we're thinking about this a lot, really, in terms of would it help if the policy landscape changed so that really this would be valued and rewarded in the profession? You got kind of incentivized in some kind of way. I'm not sure about that. We lack a critical measure of shared decision-making at the moment. We lack that, so it's difficult to bring in a policy incentive. I think that this will change when patients ask for it. And I think we're beginning to see some patients in some areas, particularly in chronic disease, beginning to not tolerate, if you like, not being taken seriously and asking for this approach. We all choose things in other walks of life, holidays, whatever we do. So the concept of giving people an option and describing the characteristics of options is not alien to anybody. Why should it be alien to clinicians to do that in medicine? And I think once we see people asking for this approach and realizing that there are harms and benefits in medicine, this will quickly change. And it'll be the professionals that will have to change their attitudes because of patient demands.
Any other question? Okay, yes, please.
Hi. I have a question about language in your tools and how you work on language so that it's easy for cultural variation and education level.
The short tools? Yeah, okay. It's a very good question. We try and keep the language in these tools to a reading age of about 12. But even then, you're completely right, health literacy and literacy issues are a problem. My own feeling is that we need to get away from the written word to a tool that would speak to you if you push the button on the iPad and then you could choose your language for which it speaks to you. The technology is already here, but we just haven't got the resources to develop these tools in that way. So that, I think, would get over some of the reading issues and maybe the literacy issues.
Thank you very much. Thank you to the speakers. Can we now go to learn something? Yes, please. Wonderful. Please write down your main ideas, and we go now to the self-management, how to involve patients in self-management.
Okay, thank you very much. And I'm here to share my experience of applying quality improvement methodology to systematically embed self-management support to improve patient-centered care. And this is the experience that's come from yet another national improvement program funded by Health Foundation, which is called Co-Creating Health Initiative, focusing on improving care for long-term conditions. And this was piloted for 4 long-term conditions across 8 sites in the country, which was COPD, diabetes, depression and musculoskeletal pain. And I've been leading this initiative at my site for musculoskeletal pain. So, aim of this talk today, hopefully, is to improve your understanding and describe self-management support and its use as a means of implementing patient-centered care. Identify tools and techniques to implement self-management support based on change package, and understand how to measure improvement in the delivery of self-management. So let's go back to the basics again. What do we understand by supported self-management? And if we look at Tom Bodenheimer's definition of self-management support, that's come from his work, his and his team's work from California Healthcare Foundation. It talks about self-management support as tools and techniques that allow clinicians or any healthcare professionals to help patients choose healthier behaviors. And it also talks about a fundamental transformation of a patient and caregiver's relationship into a collaborative relationship. So if we think about some examples, day-to-day life examples of self-management support that exists in our community, that's got nothing to do with healthcare. So think about Weight Watchers, and I don't know whether Weight Watchers is there outside UK or not, but it uses the model of peer support for patients. If you think about a website called MyFitnessPal, it not only gives you information and tools to tell you how to go about improving your fitness, but it also allows you to measure, and more importantly, it allows you to communicate with the online community around your progress and get some support from the online community. So there are lots of examples of self-management support in our day-to-day life, which we don't quite realize and define as self-management support. But nonetheless, it exists, and it exists to make change happen for us. So what would health services look like? So if there were health services that supported self-management, they would ensure that people who were living with long-term condition had knowledge, skills, and confidence to manage their long-term condition. And this might include shared decision-making, this might include setting goals, that might include motivating people, this might include goal follow-up, proactive goal follow-up, and timely goal follow-up. So lots of different ways you could do this. Obvious question, why should we support self-management? And this is a really nice diagram drawn by a person living with long-term condition, where the green line talks about the years of living with long-term conditions and ups and downs of it. And you can see the red lines, the thick red lines, which are episodic consultations. This is a problem with all healthcare services, that we treat patients to make them better. They come for acute infections, they come for an acute problem, they get treatment and they go back and they're better. But it doesn't work for long-term condition, and we've continued kind of giving this kind of approach for people living with long-term condition as well. And there is growing realization within the healthcare services that we need to change our approach from a very reactive model to more proactive, and changing those episodic consultations into more care planning approach, and thinking about problem solving in between those care planning approaches, consultations, so that we could provide continuous motivation and problem solve any self-management challenges patients have. And evidence is supportive of it. Before Health Foundation designed Co-Creating Health program, they looked at more than 600 studies that were talking about self-management support and the evidence that came out of it. The studies range from varieties of condition, from diabetes, arthritis, to hypertension and coronary heart disease. They range from different countries, and the methods that were used were quite different in form of case studies to systematic reviews to randomized controlled trials. And it all pointed towards patients improved their confidence to manage the condition. So they were enjoying their lives better, they were visiting GPs less frequently, turning up at emergency departments less often, and even if they got admitted, their length of stay was less. They improved their self-management behaviors, there was positive engagement with life, and that improved their quality of life. So what does evidence tell us about self-management support? It definitely tells us that just providing information does not necessarily cause behavior change. So we all know that we want to change our behavior, and how many of us actually have so many times put a New Year resolution to say, let's lose a few pounds this year and let's join a gym membership, and how many of you have lost some money with the annual gym membership and not turning up at the gym after 3 months of that resolution. So just by knowing that the self-management resource is available and you need to do something about it does not necessarily lead to behavior change. More active support focused on confidence and behavior change works better. And also it talks about patients' readiness to change. And this is a really, really important concept, because we've seen that lots of self-management resources are available in the community and in the healthcare services. But if patient isn't ready to change yet, then they wouldn't necessarily go and utilize them. And Judith Hibbard in University of Oregon describes the patient journey quite nicely through the different stages of activation. And if we provide self-management support that ensures that patients move in the right direction of the self-management journey by providing this support, then I think we've done a good job. So Co-Creating Health initiative was then based on all this evidence to achieve measurable, and it was designed to achieve measurable improvements in the quality of life of people living with long-term condition, but also improve their experience of health services by embedding self-management support within the mainstream health services. And mainstream is really, really important. We've seen self-management resources available sitting in isolation where the rest of the health services could carry on doing what they've always been doing and hasn't worked. It also had a really ambitious aim of delivering self-management support message consistently across the whole care pathway, that is including primary care, community care and secondary and tertiary care. And the design of Co-Creating Health model is based on Ed Wagner's and his team's chronic care model, which essentially talks about the problems that we have for people living with long-term conditions. There's lack of care coordination, lack of active follow-up, and patients inadequately trained to manage their illnesses. And they talk about, how do we change this? Overcoming these deficiencies will require nothing less than transformation of healthcare from a system that's essentially reactive to one that is proactive. And the Wagner's model talks about having productive interactions in a healthcare setup where teams are prepared, they feel confident to support their patients on the self-management journey, and patients are confident to take that role on and are capable to do so. And this, in an environment that is facilitative of these interactions to happen, produces improved outcomes. So at the heart of the design of Co-Creating Health initiative, we had 3 work streams. Self-management program, which helped patients enhance their self-management skills to achieve better confidence in managing their condition. Advanced development program, which essentially taught clinicians how to do a collaborative consultation, how to provide self-management support to patients in their day-to-day clinical practice. And service improvement program, to how to embed this learning into our day-to-day practice so that it becomes a norm. And this is quite a unique feature, and we'll talk a little bit in more detail about service improvement program. Underlying these 3 work streams were 3 enablers. So becoming an active partner, which is around setting a collaborative agenda, making sure that patients felt comfortable, confident, and had thinking time to set the agenda, identify issues that were important to them, and then moving on from there to make a change happen. So set the goal, set small achievable action plans, and build the confidence and momentum. And the 3rd enabler is goal follow-up. And this is probably one of the hardest one that we've had to implement in the existing system designs, which requires proactive goal follow-up within 14 days to 3 weeks' time, and which obviously provides encouragement and reinforcement for that behavior change to happen. It has been hard to implement this purely because systems are used to sending appointments at 4 months intervals, 6 months intervals, and we had to think about innovative ways of doing the goal follow-up, either by sending text to the people, emails, and possibly telephone reviews as well. So Service Improvement Programme is quite a unique feature of co-creating health that works both on individuals and on systems. We understand that our behaviours are often constrained by the context in which we work, as Helen Bevan was talking about in her mini workshop yesterday. And it is, if you think about it as an example, if a patient had to set the agenda, if a patient wasn't prepared, didn't have time to think about what were their priorities, or if they didn't have their test results and ask questions around it beforehand, how would you expect a patient to be prepared turning up for the consultation? So a lot of the things that were inherent in the system needed to change. And Service Improvement Programme helped us provide those tools and processes to support the behaviour change, both for clinicians and the patients. It adopted IHR's quality improvement methodology, and it basically started with local systems as they were. So it allowed clinicians, patients, managers, commissioners to come together to identify the solutions and the drivers for change that needed to be made. And some of the examples of change that eventually happened because of it were again around 3 enablers. So we developed bubble diagrams, frequently asked questions, my appointment as agenda setting tools, my diabetes plan, my arthritis plan as goal setting tools, and my health plan, emails, telephone, text follow-ups for goal follow-up. And we could share some of these examples if anybody was interested. But it wasn't that easy to measure the change. We've had similar challenges, as Glyn was talking about. How might we measure the change? And we had to overcome a lot of clinician resistance to start off with, because people didn't want to express that they were using self-management support tools and techniques in a certain way. They said, we are already doing this, why does it have to be demonstrated in a certain way? And we went about doing this by auditing the set of notes on a monthly basis. And as you can see, in first 3 or 4 months, our project assistant really struggled to find any kind of evidence, because everybody was doing it differently. And we then introduced agenda setting tool by bringing people together, making sure that people understood quality improvement methods and understood that this was a reflective tool, not looking at their performance or measuring their performance, which kind of generated a lot of confidence in the teams. And the darker line talks about the site average. There are lots of teams involved in this, which are the lighter shaded line. If you look at it, when we introduced the agenda setting tool in October 2009, there has been a consistent improvement in people using agenda setting as a way of supporting self-management. And we kind of more or less reached 100% by September 2010. Our side goal was to achieve 60% patients sharing the agenda. Similar sort of thing happened around self-management goals as well. So again, it was really hard to demonstrate or capture the evidence of goals, collaborative goals being set. We introduced the goal setting tool, and as you can see in the darker shaded line again, that over the time people got used to using these tools, and we had improvement. I've taken out all the lighter coloured team run charts just to make it easier in all the following run charts. So did we see the evidence of action plan agreed with all our patients? Yes, but after introducing the goal setting tool, there was improvement again in that measure. And we also saw improvement in the follow-up plan agreed. And this was what clinicians' perception, that they felt that they were offering patients a concrete follow-up plan. But after kind of successfully getting clinicians to start implementing these tools and getting our patients to start use these tools, we also wanted to double-check that our patients were experiencing this, not just looking at clinicians' notes that, yes, we are all doing this. And with the help of PricewaterhouseCoopers and Peak's partnership, we developed a patient feedback measure because we wanted to ensure our patients experienced all of these enablers, also felt activated, and they felt confident in managing their long-term condition. And we asked 5 questions, very simple questions, at the end of the clinic consultation, or whether it was at their home with community matrons or within the GP practice. They could simply do a yes or no answer or 1 to 10 scoring and anonymously drop this feedback into a box. And this then was collected from the clinics and different healthcare setups and fed back onto a web-based tool that would automatically generate outcomes for you, for practitioners to look at what their patients were experiencing. And the simple questions were, did they feel that most important issues around managing their own health were discussed? Did they get support in setting the goal? Were there any plans made to follow up the goals promptly? And how supported they felt in managing their own health, and how confident they were on a 1 to 10 scale? And as you can see, the outcomes, again, I've just given one run chart for you here. And the blue line is obviously run chart, and the pink line is the average. So this is what our patients experienced. They felt that what was important to them was discussed in the clinic consultation, and it appears pretty consistent across all that time from October 2010 till March 2012. It also talks about, this run chart tells you about patients' experience of setting goals with the clinical teams. And again, there's a fair amount of consistency there. This doesn't look as good. Yes, there's kind of a decent average there, but there's scope for improvement. And this is about, did we make concrete plans to check their short-term goal? And this, as I was saying, has been one of the biggest challenges. This enabler has been one of the biggest challenges to implement. And we've started now thinking about different ways we can change our services, because we know that resources are finite and we're not going to be able to get extra resources to put more people into systems. And we've been able to think about different ways of designing our services. So we've introduced group consultations. We've introduced buddies that follow up people after self-management programs. We've also introduced navigators who can motivate people and also navigate through this maze of different self-management resources that are available in our locality. And we hope to see some improvement in their goal. And this was actually reflected in their confidence as well. So because we could not implement goal follow-up as well as we like to, we also see that there is slight improvement to be made on the confidence level. Generally accepted levels are around 7, that people who feel confident in managing the condition at a level of 7 or higher should be confident enough to manage. We are reaching about 7.5, 8, but nonetheless, we would like to aim for higher. And yes, they did feel supported in managing their health, so this is a kind of direct feedback to the clinician in feeling that they're doing a good job. And obviously, that has meant that our clinicians have felt there was a big burden lifted from their shoulders. They've seen improvements in the patient's confidence to self-manage. They've seen increased reliable use of self-management support techniques, and it's certainly improved patients' experience and our clinicians' satisfaction in their jobs. Patient outcomes are obvious. Increased use of self-management skills and techniques. There has been improvement in the patient activation measure. There's increased constructive attitude towards their condition, and their emotional well-being has also improved over the time. So I'd just like to end this here by offering you a quote from one of our patients living with long-term condition at the end of his self-measurement program, who's simply thanking self-measurement program tutors. But there's a great insight in there about what he had lost in terms of, you know, how he was holding back from his life and what co-creating health has done for him in terms of giving his life back. And I think it's a great insight to end this talk with. So thank you very much.
Thank you so much. Very informative. So we have time for 2 questions. Any question for the speaker? Okay. Okay, so yes.
Hello, it's Glyn here. Would you elaborate on which conditions and roughly how many patients were in each centre?
So the conditions, as I said at the beginning, were musculoskeletal pain, diabetes, COPD and depression. So those were the 4 conditions we were piloting in. And in terms of patients who participated, it varied depending upon the condition. So there were challenges around patients with depression and COPD enrolling them on a self-measurement program purely because of the nature of the condition. But if I was to give experience from my side, over the last 4.5 years, we have enrolled about 250 patients on the 250 patients have completed self-measurement program, and there's I couldn't tell you how many patients have actually experienced self-management support on a one-to-one basis in day-to-day consultations, because that's a huge number of people. So in terms of, just to give you a little bit of understanding, how many people have undergone self-management support training, at our site about 125 people have completed self-management support training. And those are kind of numbers we're looking at.
Oh, yes, please.
Dimple, your self-management...
Do you mind using the microphone,
Sure.
please?
Your self-management training for providers,
Yes.
do you segment that to different levels? Are there people that are more engaged around the goal setting that get different kind of training, for example?
I think you're absolutely right in thinking about segmentation. And we did this work at our site when we were looking at embedding some of this as a part of our services, because we already had some options available from our primary care trust for people who worked in the public health domain, people who were working in the adult social care and reablement arm, and other people like physiotherapists and doctors. And we realized that not everybody needed this level of training, which is quite in-depth, and sometimes we found that some of the community staff struggled with the training and the skills rehearsals. So we've kind of developed a modular approach, and we have a very basic module, which is for people coming from practitioners from adult social care and for community staff. And then they move on to more of a care planning approach, which is module 2, which is a day and a half of training, which essentially talks about changes you need to make in the systems, in the administration, and works more at primary care level. And then we moved on to self-management support as described in Advanced Development Program for Co-Creating Health as Module 3. And we found that people, GPs and hospital clinicians and physiotherapists have found more comfortable to attend this sort of program. And there's nothing to stop people accessing these programs if they felt the need for, but they would have to move up the different modules. So yes, we've kind of thought about that and segmented the training.
Thank you so much.
All right.
Thank you. So please, the next speaker, we are going now to the TripAdvisor. What is this? It must be very interesting. Where are we going with this TripAdvisor? We don't know. So in the meantime, do you mind introducing yourself to another person next to you very quickly while he's getting ready? So you are going to learn someone new. Congratulations. Very, very nice. And I want to learn something. Are you ready? Okay.
Like water. Right, very good.
That's good.
Right then. Well, thank you very much. If I could call you back to...
We are ready to go to choose. Okay. Please continue later. So, Dr. Greaves?
So my name's Felix Greaves. I'm a junior doctor and a public health registrar from the UK. I work at Imperial College. And I'm going to talk to you over the next 20 minutes or so and then hopefully have a little bit of discussion about the idea of TripAdvisor for Health. That's patients rating their own care online. And it's a relatively new thing. Having received some feedback at the start of this session, I will try to talk relatively slowly. If I'm going too quickly, which occasionally happens, do wave, heckle, or whatever you would like to do to let me know, because as the theme of this session is, feedback is good. Thank you for that earlier on. So the internet's really sort of altered the way we do a lot of things in our life, particularly the way we receive information. It's profoundly affected most of us. But sort of the new way of thinking about the internet, what the jargonists would call Web 2.0, suggests that it's actually more of a two-way track, a two-way conversation. Not only do we receive the information, but we also broadcast our own. And we do that every time we like a comment on Facebook, every time we upload a video on YouTube, and also every time we rate something online. And I think we found that we actually really like rating things on the internet. The hotel I stayed in over the course of this week, I chose partly on the basis of the reviews I saw on TripAdvisor. I don't know if anyone else want to raise their hand if they did something similar when they were doing. Very good, quite a lot of people. And some people maybe just went straight for the conference hotel. This has sort of parallels in how people choose their hospitals, actually. We rate books online, we rate the seller on eBay. We actually started rating slightly more, which is not just things, but services. We rate the teachers that we get. In the UK, you can now rate your own police service. But let's not get too distracted by this, and let's think about health, because we do a lot of this stuff in health too. And we found that, people like rating stuff, and when they like it, a market develops around it, and people come forward and provide the platforms to do it. And we've seen a lot of these. In the US, you've got quite big ones. This isn't even the biggest, Rate MDs. In the UK, you've got I Want Great Care. You've got patient opinion. There's a whole sort of growing marketplace of these places, these locations where you can go online to rate your care. And they are becoming increasingly more popular, but they also do it in different ways. Patient opinion, you see, you rate a hospital. This is a rating of St Mary's. I Want Great Care. Behind you can see an individual clinician. And so there's different ways of doing this, and I don't think we've really sort of landed on exactly what the patient wants to see and what people are happy with at the moment. But so we see a broad spectrum of ways that you can rate your care online. Are people doing it? Is it increasing? Is this actually happening in healthcare? Well, the data's not that good, but there's some new stuff, and this was from a team in the States that came out only a couple of months ago, led by, Nhs Choices from Harvard. And you can see the blue line at the top is the number of ratings. It's not exponential, but it's upwards, and it's quite steep. So I think we can be confident that this is a growing phenomenon. More patients are taking the time to rate their care online. What do the clinicians think of it? Well, this is the headline. This is the paper. We see that GP fury over poison pen online tirades. I don't think this is every clinician, every physician, but it certainly reflects some of the feelings that you get back if you go and ask healthcare professionals about this sort of thing. It's a bit of a challenge to them. So I've tried to distill down a few of the reasons why these websites are good, bad, but I mean this is from conversations from reading the very small literature in this area. Why it's bad? One of the main reasons is it can strain the doctor-clinician-patient relationship. Doctors, what the patient wants isn't always necessarily what the patient needs. The classic example might be perhaps prescribing an antibiotic for what's likely a viral infection, and therefore a doctor could do the right thing but still get a bad rating. So doctors don't like that. There's a real possibility of people leaving fake or malicious reviews. This happens in all spheres, happens very commonly on TripAdvisor, and does happen in healthcare, but it's not that common, but it's definitely there, and it's definitely a risk. My epidemiologist comes out. There is a selection bias. The people leaving these reviews come from either end of the spectrum. The people that had the best care or the people that had the bad experiences. And so doctors don't think it really adequately reflects what they do on a day-to-day basis. It just picks up the extreme events. That might be interesting. And there's a question about, does it actually mean it? If a patient makes a decision on the basis of this, does it reflect the technical quality of care, the sort of things that we, as maybe quality improvement people, would think would be rational reasons to choose your hospital? But there's reasons why it could be good. We know that doctors are often bad judges of their patients, of what their patients made of them, of what happened in that consultation. And we also know that feedback, appropriately done to doctors, can improve their performance. And my last reason is perhaps the most practical, is that it's happening. This information is out there. Why don't we take this information and try and use it for good? So where we are, they're becoming more popular, they are controversial. We don't know the relationship with hard measures of quality. So if we're going to understand if these measures, which are occurring, have a place in what I think someone else rather beautifully described as a patchwork quilt of quality measurement, all the different ways that you can look at quality, we do need to think about a few things. We need to think about who's using them, how much they're being used, and how they compare. We got lucky in the UK because the government does it. I don't know if the government's necessarily the right role to be doing this sort of thing, but there's a website called Nhs Choices. This is a national comparative data website listing all hospitals and general practices in the country. It provides data on them, and it provides the opportunity to leave feedback. This is a real rating for a hospital, the John Radcliffe, where I did my first job. And because it's a government thing, we were able to get hold of the data. I still feel a bit guilty about this, but I applied under the Freedom of Information Act to get hold of the data. It's not classical method necessarily. I sent my letter to Richmond House, this is the home of the Department of Health, and to my great surprise, I said, look, please can I just have all of your data? They said yes. They said, no one's ever analysed it before, that would be great. And what's more, the data is now on the data.gov UK website, so if anyone else wants to have a look at it, there's all sorts of wonderful things and very under-researched field. So we took this data and we thought, let's compare it at the level of, the data is at the level of hospitals, not clinicians, as we took hospital trusts, the organisational unit of the health service in the UK. So that's a hospital or a small group of hospitals in a similar area with the same management team and set of policies normally. And so we compared what we saw on the ratings with what we saw in the big patient surveys. So we do big random patient surveys, sort of tens of thousands, or hundreds of thousands are sent out, tens of thousands are returned. We compared to measures of qualities, things like standardised mortality rates from the Information Centre, from Dr. Foster, from the Health Protection Agency for infections. And what did we see? Well, 2 years' worth of data, 10,000 ratings. Every hospital had ratings. The average hospital had about 50, and on the whole, I'm going to say quite a lot of big sort of tables, but I understand people don't really like these things, so distilled messages are normally in the middle of them. The majority of ratings are positive. These aren't just used to gripe and complain. 67% would recommend to a friend the hospital that they went to. Now, that's not that high, but it's only about 80, it's sort of 80-something% on the randomised surveys, so there's a bit of a selection bias, but it's not massive. Aha, first table. I like a p-value, but I don't want to bore you with it too much. We compared the questions that were asked on Nhs Choices, because they ask a number of set questions, and we used the ratings rather than the free text responses. They ask a number of set questions, and we compared them to the most similar question in the patient survey. Here you see what we have are associations. The take-home message is there are definitely associations that exist. Hospitals that rate highly on one particular score from the rating on TripAdvisor rate similarly in the ratings that in the responses to the surveys, whether that's on would you recommend, was I treated with dignity and care, did the staff work together. So yeah, so it's not, you're getting not the same results as a survey, but there are associations, they're not completely different. Then it gets a little bit more potentially fruity. We compare to outcomes, and I appreciate there are issues with this methodologically, and I'm totally willing to sort of think about those or discuss those. But we saw the same thing. For some things, the portion of patients recommending the hospital and the mortality rate, hospitals that get better ratings have lower mortality. It's not a huge association, but it's there. If you went on to cleanliness compared to MRSA infection rates, same thing. The patients think the hospital's clean on the TripAdvisor system, they tend to have a lower bacteremia rate. Interesting. So we took these together and we thought, actually, though it's not a perfect reflection of technical quality by any means, in fact it's a fair way from perfect, there is an amount of appropriate technical technical ability represented by this data. Quick historical diversion. This chap is Sir Francis Galton. He was a Victorian, a polymath. He invented all sorts of wonderful things in his life. He invented the weather map. He invented the concept of correlation. And he also spent his time going around the country fairs of Victorian England trying to guess the weight of bulls. Because they had competitions to guess the weight of a bull, a large cow. Rather than do it himself, he let others do the heavy lifting. And rather than going asking the experts, he compared how everyone else, like large numbers of people, had guessed the weight of the bull. Then he took the arithmetic mean. It was normally much closer than the experts would put it. And this concept has grown in current theory as a wisdom of crowds, publicised by James Suriecki and others. So I'm not saying the crowd of patients on TripAdvisor is right all the time, but in that self-selecting group of patients that choose to rate, there is a flicker of wisdom from that crowd of patients. So if I were to compare two sources of collecting data, two ways to biopsy the patient voice, you would see that you've got the surveys and you've got the ratings. One's more one you get a lot more responses than the other, but the other one might be a bit cheaper. So actually, you've got two things here that could potentially be a little bit complementary. However, before we get too excited, let's think about the scale of these things. These things are quite rare. There were 10,000 ratings over 2 years. In that time period, there were 29 million hospital admissions in the UK. That's 0.04% of hospital admissions rated. So don't go getting ahead of yourselves. These are rare events still. But they may contain really quite a lot of information. When we compared the patient survey with clinical outcomes and the patient and the NHS Choices ratings, the TripAdvisor ratings with clinical outcomes, the ratings had just as strong an association, maybe even stronger, even though there's far fewer of them. Perhaps that's because they pick up the extreme events, those examples of really bad care that a randomized survey would miss. So next, who is doing the rating? Well, this is a map we drew. To do this, we looked to see who was rating GPs, primary care practitioners. And this is ratings per 1,000 patients. People who know the UK would see that this is something like a map of population density, but that's already considered. So we're seeing that there are more ratings occurring in cities like London, Manchester, and some of the northern cities, less used in rural communities. So we did a bit more analysis, more p-values, but what this comes down to is that practices serving younger people are more likely to be rated, practices serving less deprived people are more likely to be rated, practices in urban areas are more likely to be rated. So again, we have to stop, pause, and think. Who is our stereotypical reviewer? Is it someone in their cafe in a city on their iPad ordering their skinny mochaccino latte? And if so, is this a great way to collect information about patients and their experiences? Because it's a very biased group of people, and I think we also have to accept that. And at the moment, while this is a relatively niche activity, we're not listening to the voice of all of the patients we serve. We are listening to a relatively small proportion of it when we listen to TripAdvisor-style ratings. And I wanted to put up an actual rating for you to look at. I have occasional moments where I think maybe this stuff is nonsense. Maybe this stuff is, I'm overextending an analogy of the usefulness of social media into an area where perhaps it's not really there. And then, so this was published on the day I published my first paper on this. This is my own hospital where I work at Imperial. And when I read it, I see that actually it's rather a difficult message. It's not very pleasant to read. It's angry. It's rather sharp. But it contains some really interesting stuff about the quality of care that was provided. I'm not certain that this is real, but I think it probably is. I don't think it was recorded in a patient survey. There wasn't a complaint about it. It wasn't captured any other way. This is the only way, probably, that this patient has tried to make their voice heard. And it's there. And if that organisation does not hear this story of, perhaps inappropriate clinical sort of care on a ward and not being looked after, it's not the nicest way to hear this message, but it's a voice that would otherwise not be heard. So this sort of makes me think that, well, maybe there is something in some of this, in the depth of these messages, particularly in the free text that you read. Also, I'd just like to think about quickly learning from other industries. The quality improvement has learned a lot, from Deming in total quality improvement to sort of Gawande checklists in aviation. Well, ratings like this are used very commonly in other industries. companies pay to have their products rated. This is a company called Review, who work down the road from me in London. And they get paid a lot of money by manufacturers of electronic equipment, cars, all sorts of products, to get reviews and to send them back to the company, because they know, the company knows, just how valuable they are to improve their product. And so I'm thinking, well, perhaps again, here's another area where we might learn a bit more about how to do it, and from other industries. So I've got a few thoughts, and these again are more sort of conceptualizations than just having looked at the data for a year or so now. We find that when people leave ratings, they really expect a response. Nothing makes them angrier than not hearing back. And so organizations just think about how to do that, because it's difficult to get the right tone. It's difficult to get the right timing. You respond immediately and then do something more a bit later on. It's really hard. Ratings provide information for two things, both for organizations to improve and for patients to choose. And you've got to remember the duality of it. And thirdly, there is potentially this really rich information that isn't captured in any other way contained within these ratings. So as I try and bring my thinking back together, we see that this is a phenomenon that is increasing. We see a phenomenon that has a lot of resistance against it, particularly from certain aspects of clinical communities. We see there may be wisdom in the crowd of patients, or at least the self-selecting crowd of patients. We see a biased group of people that we're listening to, but then again, an increasing number of voices. And we see other industries doing this stuff really, really very well. And I can't help but think that perhaps the traditional ways of collecting data of our large-scale surveys, be they electronic or paper, would benefit from the additional information. I'm not arguing an or, I'm arguing an and. But the information captured by these ratings websites is potentially very useful information. And we should think about, or as organizations, encouraging their use rather than trying to pretend that they're not there sometimes. And the final thing, just to get a bit more sort of pushing and looking into the future, is there's actually an awful lot of information out there on the internet about people's care, about people talking about their experiences, and we don't capture it at all. You could look, for example, at the blogs where someone describes going to visit their grandmother, the newspaper articles in local papers that sort of aren't systematically collected, Facebook comments, Twitter, like all the ratings websites. Actually, if you were to take all this information and find a way to collect it sensibly, boil it down, you would have some really quite interesting, quite real-time information if you use the right forms of sentiment analysis. Now, this is looking to the future, I give you that. But there is a cloud of patient experience out there, and if we can mine it, there might be gold in there. There's a lot of rubbish in there, I'm sure, but there might be gold as well. I don't know. More things to think about. So as I listed and non-hierarchically, the various people that helped me in this way, the questions I would put out to you is, do your organizations think the right way about what are they doing about ratings? Are they responding to them? And are you listening to all the voices of patients that you can via these new mechanisms, means, electronic forms that are becoming more common? Yep, I think that is what I have to say.
Thank you so much. Wonderful. This is creativity, in my opinion. So, any question to our... Yes, please.
Thanks for a challenging presentation. We have a lot of surveys. We have a lot of info coming in on patient experiences in your country as well as in mine. I'm from Denmark. Oh, sorry, Peterbana, Central Denmark region. If we should take resources and put it into these blogs or more or less self-selected sources of information, what should we do less of? I mean, we have a restricted source of resource. If we should do more of this, then what should we do less of? Less of the official complaints, less of the national surveys. Should we close our own blog sites? What should we do less of?
I fully take your point. In a resource-limited environment, what do you do? I think that, bar the stuff at the end, which was sort of novel and requires research and expense, the other stuff really doesn't cost a lot. You know, the other stuff, it's being put out there in most countries by the market. People are creating these websites. And this information is coming to you to an extent for free. Now, there's extra capacity to analyze and to respond. But thinking about it, it would probably be a more cost-effective way of capturing the patient voice than sending out a stamped addressed envelope on a patient survey, which is what we still do in the UK. Well, potentially this would enable you to reduce some of that cost if you thought you did get enough good information from these sources. I don't think we've got there yet, but I don't think it's massively cost inflationary, this.
Jan Watt, please.
Thanks. My name's Ian Watt. I'm a GP in England. I just wanted to share with you an observation of being on the receiving end of feedback. We've, as a practice where I work, we've had the patient surveys, and we're not bad. There's room for improvement, and the patient surveys furnish us with useful information. We've had 2 online comments posted about the practice. One of them questions whether any of the staff there are qualified, and the other one insists that we made a patient crawl to the practice when they had a broken ankle. Both of them were anonymous. Now, I'm not furious about those. I'm not angry. I'm kind of saddened that people felt that way about the practice, but I didn't find them particularly useful to do anything to act upon. So I'm not against the electronic feedback, but I think we really need to do something to help make them a little bit more constructive than the 2 comments we've got so far.
I've heard similar stories from many general practitioners in the UK, and I absolutely agree with what you're saying. There are flaws with this system. The fact that you can be anonymous and really does substantially sort of reduce the use of it. If you look at what some of the commercial companies do, they put in extra functions that require people to be identified, people who've recently used the service. Another way of doing this might be to just email out to everyone who's been into your practice or your surgery and ask them to rate or something like that with specific codes that meant that you knew that they were the real person. There are technical solutions. They are complicated and expensive technical solutions. So I see that at this moment, particularly for small organisations where there aren't enough ratings to generate a representative picture, they are not so useful. And I agree, in general practice at the moment in the UK, they are not as useful as for hospitals, I would think. So I absolutely understand your concerns.
Thank you.
Hello, I'm Carol Sinclair. I lead the National Patient Experience Programme in Scotland, and this has been really brilliant for me because I'm attempting to do all of this as you describe, and many of the comments today I recognise. So I just wanted to thank you for an excellent presentation, and I think that by coming together and sharing our wisdom and sharing our learning, we can help people move forward, because I think you're right, the additionality and the managing of resource and investment is a vital question, and it puts this as a dimension of quality at risk. So I would like to explore further with you how we share our learning across the border. Thank you.
Thank you very much. Any other questions? Yes, Richard?
Thanks, Richard Thomson, Newcastle. I think one of the questions I'm keen to explore with you is, who do you think are the primary beneficiaries of the sort of information you've described? Because I heard from the way you described it that it was fundamentally the provider that was a beneficiary. And yet, many of the examples you give, TripAdvisor, for example, are in a way targeted at the user. And this links back into some research that people like Martin Marshall have done about publicly available quality data and who are the primary users and responders to those, and it tends to be more the provider than the user, the customer, the patient. And I can see from the way you've described this that there may well be some very valuable messages for a provider to mine here. I find it very much harder to see the benefit to the patient in the context of choice of provider.
When I commented on the duality of this function, that it exists to inform the patient, and it exists, as an opportunity for quality improvement. And I do see both sides, and you see different organisations, different websites that are aimed at different things. I Want Great Care, for example, is all about picking the right physician from the patient's point of view. Patient Opinion is more about helping the organisations to learn. And I think there's a tension within the small community that do this about what the end result of that is and what the main aim is. But we're currently looking into those questions of how much do people trust these when making decisions. Is it still, how close are they? Did my nan go there? Is the car parking all right? Or does this stuff, or particularly, stuff, or comments that are left by people you know, sort of your Facebook friend, would that be more influential in changing your mind about which hospital to go to? At the moment, I don't think we know the answer to that, but we are looking into it.
Okay, any other question, comment? Yes. To Felix or the other speakers too, of course.
Hello, Richard Wilson from West Midlands. It's quite interesting because all the stuff you're talking about is very much a policy area, because the patient opinion stuff is now part of PCT assurance packs, which are now going out to various PCTs, as are visited by David Nicholson and various great embassies. A PCT, Primary Care Trust, it's the regional policy commissioners. So it's all part of, it's a growing agenda, and that cloud has already been mined. CQC are already working on it with Deloitte's in terms of looking at the media, the Facebooks. It's the GCHQ model in terms of the stories. But also because now with Cameron, Friends and Families question, which was raised, David Cameron, our Prime Minister, about asking every patient in every situation whether they recommend. And it's interesting what you're talking about, who gets a benefit from and how you ask questions, because in the Midlands and East, which is basically the size of Belgium, we're asking 10% of people who are discharged from hospital to rate their care. Would they recommend? And the interesting thing is we're looking at all the different methods. So it's both postal, tablet, volunteers, nurses doing it. So it's a whole wide range. But the interesting thing is the comments coming back from hospitals are twofold. One is, what's the rules? Because it's an incentivised payment. So they're all interested in what's the rules, not how to improve, because they're asked straight away, what's the rule, what's the rule, what's the rule? But secondly, when you ask the question, they're getting patients coming back and saying, well, I've had a heart attack. Wouldn't want to recommend this service anyway, because I didn't want to come to hospital. So they're quite interested when they're asked, would you recommend this service? They're like going, well, if you're planning to have a heart attack, yes, but don't have a heart attack. So it's just quite interesting how we communicate with patients. And I think that's part of the biases we start to see. But also, what you missed out by saying it's a biased group is a lot of the people who will be involved in rating will be the carers, the family of the people who've had treatment. And I think that's an interesting aspect, which is clear that the people who are actually doing it and over our coffees are probably the people intelligent enough, well, influenced enough with the social media or the iPads and everything to do that. But it shouldn't exclude the fact that the people rating might well be the carers who would actually rate the hospital, what they see in the environment, in very much the way the person's rated that. They might have seen the care as being very poor, but a patient would actually say, I came out alive, I'm so grateful. They did me no harm.
I agree with what you say, and careful question selection is clearly very important.
Okay. Any other final? Okay, final one. They have something to tell you?
I'd just like to endorse the comment of the last speaker. I've had relatives in hospital recently. The hospital had no idea just how bad they were. They had no idea at all.
Okay. Thank you, Felix, very much. And thank you also for putting us in a new dimension, may I say. We really need to face the future, which is now, because we all always are in this technology world. So I kindly invite you to bring to the next forum all your experience, your point of view, and the new challenges that you are facing. Before I leave, I want to thank you very much again, all the speakers. You, and please, before leaving the room, introduce yourself to another person with a new idea you got. Thank you very much.